Hello, Dr. Kiran here. Today's topic is on even good implants do fail. Remember that. So, what happened here? There is a screw hole through which helical screw blade of PFN A2, which is supposed to be very strong, broke. This belongs to a patient who was operated with this 36 years old female and not made to weight bear because the doctor was little doubtful about the bone quality, and he had given her parathyroid hormone injections. Okay, so when she came to me with this situation of broken proximal end at the screw hole, which is normally that is the area of stress riser, I also noticed while removing. So see the quality. It has lost its rim while removal. This just gives us a message that implant was indeed of poor quality. Now here, this patient was operated 5 to 6 months ago by a very good surgeon. Patient is brought to you and they ask, "Sir, please help her." Yeah, but what kind of company was it? So who supplied? Unless I know that, the problem is, do you see the difference between these two? This is a single slot, and this is star-headed. Implant removal is always very difficult compared to application. The screw holes, which are supposed to be hexagonal, they become round. The implant's strength is not good enough. When you screw the head, the screw becomes round, and sometimes we get caught midway. The screw doesn't go in. So we have to carefully, not overdo it, very carefully judge the implant quality. Where I always judge, if it is just it's tipping, then I remove it because I don't trust the screw anymore. Not only during application, for the implant remover, if the need arises, it is a hell. There was a beautiful article written, don't take it out on a fracture table. This orthopedic surgeons will understand. Normal people won't. So lateral position, use a DHS extractor and it will come out easily. That's exactly what I did in a lateral position. My assistant was saying, "Sir, why sir we'll put a traction table?" I said, during insertion it's okay, but when you remove it, you won't have the visualization. Better we put laterally like a normal conventional nail remover or something, and then we see it and remove it. That's exactly how we could remove all these things. Okay, and here I would like to tell you, it's very important not only to know how to put an implant into the bone, in case it breaks, how to remove it. These are my 20 years old property implant removal sets. So from the greater trochanter, I put this conical nail remover handle and screwed it in, got the grip and punched it out, and it came out. And for this I used this, and again the same thing, I screwed it in and punched and pulled it out, tap, and it came out. What I'm trying to tell you is, there are many methods, many broken screw removers, broken nail removers, and other things, techniques which you must be aware of, and you must be a proud owner of, whether you're in the government or in the private. Good luck, because implant removal is sometimes more catastrophic. You may create more holes into the bone and create more problems than a fresh implant application. Could this be avoided? This confusion for implant removal? Yes, if only the doctors, by a mandatory self-discipline. You cannot impose a discipline on anybody. They have to learn it. So PGs, postgraduates of orthopedics, please in your discharge summary write the company, the source of supplier in your local area, because when we remove, if need be, we don't want to end up taking this to the operation table and seeing a single slot. Nowadays nobody uses this kind of a screw head, but it does happen. So I went and asked them a DHS, because it's still non-union, PFN A2 again, normal PFN, recon nail, proximal femur plate. It was like a full-fledged war zone with which I went in. Bone cement also I took a bone cement. Only thing I didn't take is a modular partial hip replacement set. Why did I prepare so much? You better prepare than feel sorry. Already the patient is suffering since 5 months. So this all could be avoided just by writing the company's name, the source of supplier. That's finished. You have done your job, and it helps the patient immensely. Also, the patient, when they go for an MRI, if you don't write stainless steel or titanium, suppose the patient develops a vascular necrosis, not the fault of a surgeon always. It can be due to the trauma itself, and they want an MRI, and this helical screw blade is of steel. They cannot, they have to have the information. The MRI technicians, they'll say, sir, we don't know, so it's not safe. So you go for any other thing, and the artifact, the steel will give out a lot of reflection and will compromise on the quality of reporting. See how much you ended the patient in, how much unwanted, unnecessary turmoil, tension, and unnecessary wastage of time. So just 2 lines, doctors, orthopedic surgeons, medical assistants who write the notes. Please ask your orthopedic surgeon, sir, what is the implant? What is the size of the implant? Which supplier in this area supplied it? It's mandatory. Otherwise, stick a sticker from the sterile cover on the discharge summary so that you will know the details of the implants. That's not difficult. Also, during immigration security checks, it's better to write in a discharge summary properly. ORI done, open reduction until fixation done. Not enough. Just say there is a metal, because ORI, I and you understand as orthopedic surgeons. What will an immigration or a security checking guard, they will understand. Because today everybody are doing everything, cut and put something there. My message is, please do not end a patient in trouble either in the MRI room, during implant removal, or in the security checks. Just one copy of proper information will do the trick. So internationally, this is to be made mandatory, because not only in India, I have seen in many other countries where the implant details are not given. So thank you. Please, orthopedic surgeons, do this for your patients. It will go a long way in your own practice. Thank you. Bye-bye.